Hello friends, once again in our channel I'm discussing one of the important clinical anatomy topic, that is anal canal. This question and this topic is not only important for examination point of view, that is one of the important topic, additionally is having many clinical aspect. The distal part of the GIT, the distal part of the GIT, the distal part of the GIT is divided into several parts, and this is holding many clinical features, anatomical features which are concerning with the clinical aspect. It having unique feature, many unique feature which is having which is concerning with the many clinical aspect. So दोबारा करो, बंद कर दिया जब मैं बोलूं तब. Hello friends, once again in our channel I am discussing one of the clinically important topic, that is anal canal. That is the distal most part of the GIT and it's a pathway for defecation. This is the anal canal. This anal canal, which is almost measuring only 3.8 centimeter, or you can say that 38 millimeter only. This is having 38 millimeter only. This is 38 millimeter only. 38 millimeter only. This is having a many unique clinical feature which make having a part of many clinical applied anatomy. Okay, so this whole anal canal is divided into 38 millimeter, or you can say 3.8 centimeter, is divided into three part. Okay, part number one, this part is separated from this curved line. That curved line is known as pecten line, and another line which is at the junction of middle and lower aspect. This is not so curved, and this is known as Hilton's line. This part is upper part which is separated from the pecten line, up to the Hilton's line. This part up to the pecten line, this is 15 millimeter. The middle part is 15 millimeter, and last this part is 8 millimeter. So total is almost 38 millimeter or 3.8 centimeter. This is the length of the anal canal. Now first of all, before discussing the clinical feature of the anal canal, let's discuss about some of the relation and the unique feature. This anal canal is developed from distal part of developing gut, especially the upper part, and also proctodium part, that is the invaginated ectoderm, both. So this having the features of the skin also, the feature of the developing gut also. Okay, and because of these all kind of feature is bear a great clinical importance. Okay, now first of all, the relation of the anal canal, and you know the anal canal is anterior relation to the perineal body. the perineal body. Anteriorly there is the perineal body. Anterior to the anal canal there is a perineal body along with bulb of the penis in the male, and if it is a female, that means the urethral part is there, the vaginal part in anterior relation to this anal canal. Okay. Posteriorly there is a coccyx, and up to the anal canal there is the anococcygeal raphe. The coccyx, and from the coccyx there is the anococcygeal raphe posteriorly. On each side of the anal canal, when we discuss about the ischiorectal fossa, there is ischioanal or ischiorectal fossa. If I want to draw this, there is a filled space that is known as ischioanal fossa, ischiorectal fossa. Simple, very simple. The anteriorly the perineal body, the bulb of penis, or in a female there is the vaginal part. The posteriorly, if you put your hand on a surface and marking, there is the tip of coccyx and the raphe, that is known as anococcygeal raphe. In each side there is the ischioanal fossa or ischiorectal fossa. These are relation of anal canal, and just this is the 3.8 centimeter or 38 millimeter of anal canal that is divided into upper 15 millimeter, the middle 15 millimeter, and the lower 8 millimeter, overall 3.8 centimeter. Okay. Now anal canal is this anal canal having particular specific features in each part. Why these parts are separated? Why we are considering these part in a first part, second part, and third part, or upper part, middle part, or lower part? Because these having unique feature, and on basis of unique feature, there may be several kind of change in the body. Okay. This is, by the way, this is not a straight canal. This is not a straight canal. If I am drawing it in a sagittal plane, I can draw like this. This is the anal canal, and there is twisting of anal canal. There is twisting of the anal canal. This is the twisting of anal canal, and the posterior, the anterior wall of the anal canal. This is the anterior, supposed to be the anterior wall of anal canal is shorter in comparison of the posterior wall of anal canal. This is posterior wall of anal canal. Okay. One more thing. There is a curvature. There is a curvature, and they say this curvature is due to a sling. This is a sling which is surrounding the anal canal, and this sling is known as puborectal sling. Pubo, from pubic part to the puborectal sling. Anyway, by any mean, the function of the rectum plus anal canal is to hold the feces until unless there is a messaging of a proper area or brain control that you can defecate. Okay. So this sling is also one of the measures which is holding. As in the rectum there was several fold was there. This is the puborectal sling. Plus another many things are there which is holding the feces and waiting for a particular environment and area which is according to the which is suitable for the defecation. Okay. So this is the puborectal sling which is making this anal canal curve, and anterior wall is shorter in comparison of the posterior wall. Okay. So this 3.8 mm canal, that is a continuation, the distal continuation of the rectum, that is curved anterior posteriorly, and there is the puborectal sling. Now I am moving toward the specific features of the anal canal. Okay, when we are talking about the specific feature, we will move from part 1, that is the proximal part of the anal canal, the proximal part of anal canal, the middle or intermediate part of the anal canal, and the lower part of the anal canal. First of all, the upper part of anal canal. Upper part of the anal canal is developed from the developing gut, primitive gut. So this is having the almost similar features. Okay. the mucosa is there. The clear cut, the mucosa is there, and that mucosa is made up of columnar epithelium, as throughout the GIT, from the lower part of esophagus, there is stomach, and so on. The epithelium is made up of columnar epithelium. The same, the epithelium here is made up of the columnar epithelium, but underneath the epithelium, there is shadowing. There is a shadowing of the columns. Okay, I am drawing here the column number 1, and there the shadowing the column. These are the columns. These are the columns, the column number 1, and so on. Underneath the mucosa, the vessels are coming. That is the radicals or terminal longitudinal branch of the superior rectal artery as well as the superior rectal veins. These are the prominence, because underneath these cords or column there is branching of superior rectal artery or the superior rectal vein. You can see underneath the mucosa, if you are putting something longitudinal, that will appear like column, and these column are known as anal column. Okay, very simple. If this is a plain mucosa, this cloth is a plain mucosa, and putting this chalk piece here, it is prominent. Next one, if I am putting another chalk here, that is second. And now this kind of column are present throughout the anal canal in upper 15 millimeter, and these are known as anal column. If I want to draw the radicals of superior rectal artery as well as the superior rectal vein entering into these columns, along with the part of muscularis mucosa is making them prominent. So these are anal column. So what are the anal column? Anal column are projection, longitudinal projection in the mucosa due to the radical part of the longitudinal radical part of the superior rectal artery and superior rectal vein, along with the muscularis mucosa. Due to this, there is an unfolding in the mucosa, and these are anal column. But somehow these anal columns are not continuous. They are terminating here, where they are terminating some kind of frilling type of cusp wall are present. Okay, you can assume a curtain of a huge show. These cusps, okay, where one column, this column is ending, where the one column is ending, another column is ending, there is a continuity, this is a cusp. These are known as, these are mucosal foldings whose distal part or inner part is upward projected, cup-like or cusp-like. These are known as anal wall. So these are the anal wall. These are known as anal wall. Ending part of the column, mucosa is still folded and forming a cup-shaped structure that is known as anal wall. This cup-shaped structure, you can assume these anal wall in continuity throughout the anal canal, forming a line that is known as pectinate line. That is important aspect. Or suppose, what is this? Is a one cusp, another cusp, a continuous line throughout the anal canal forming the pectinate line. Okay. One important thing about the pectinate line or about this anal wall, there is epithelium which is derived from the primitive gut. So there is the columnar epithelium. And the lower part, there is epithelium which is developing from the proctodium, that is the non-keratinized columnar epithelium. So non-keratinized stratified is squamous epithelium. The epithelium on the both side of anal wall will change. This continuity of 1, 2, 3 anal walls throughout the anal canal, forming a line that is known as pectinate line. This is a very, very important line, pectinate line. Pectinate line separating the upper 15 mm and intermediate 15 mm. Okay, so anal column and anal cusp. Not only that, above this cusp, you can see I'm forming here this one. The duct are opening, and these ducts are of anal glands. These ducts are of anal gland. Okay, suppose this is one column, this is another column, and in between them the cusp is there. The glands open. These cusps are more prominent on the posterior aspect of anal canal, and glands are opening into this cusp. Okay, these are important anal cusp or anal gland. Okay, anal gland are opening somewhere here. Anal glands are opening somewhere here. Anal glands. These are anal glands. Anal glands. Okay, anal gland. Sometime a mucosa that is lying in between these columns, in these columns, due to the strain, may project downward. I'm just hypothetically forming this. This may be forming the anal papilla. Anal papilla. But this is the mucosa which is due to the strain forming a papilla and projected below the pectinate line. So one thing is clear, above the pectinate line, the developing gut is forming the upper 15. Below the pectinate line, the intermediate or lower part is developed from the proctodium, that is an invaginating ectoderm. The upper part, endoderm, below this ectoderm. Upper part is supplied by the autonomic nervous system. The lower part is supplied by the somatic nervous system, that is pain sensitive. The upper part is draining into the internal iliac lymph node. The lower part is draining into the superficial inguinal lymph node, and these all are following the rule of the development. The part which is developing from the primitive gut or developing gut is going toward the visceral side, and below this going to the somatic side. Okay, and each of them, if the superior rectal veins are there, which is a continuation of inferior mesenteric vein, which is a part of the portal venous system, it is merging. I'm drawing the middle rectal vein here. Middle rectal vein here. The middle rectal vein which is passing through this one and forming a plexus in this zone. That zone is known as pectinate zone. The intermediate one, the intermediate part which is purplish blue in color, due to underneath the venous flux is irregular. Here was the venous and vessels fluxus which was longitudinal nature. The next 15 millimeter having a venous fluxus which are plexiform, really plexiform, and this is concerning. This is also anastomotic with these radicals, and this part is known as pectinate part. So intermediate part having the plexus which is having the form by the middle rectal vein and inferior rectal vein. If I can draw, there is the inferior rectal vein and the middle rectal vein. So this part is purplish blue in color. The upper part was pinkish hue in nature. The intermediate 15 mm is purplish hue in nature, and there is a clear-cut pectinate line. That pectinate line is a curved line due to the anal wall, and this is the feature of this one. Okay. Lastly, before going according to the feature, before going toward the clinical aspect of the anal canal, the last part, and this last part actually this is the skin, and I am drawing these ridges and some kind of corrugation, a corrugation. Why I am drawing this corrugative? Because the external anal sphincter is creating dimpling in the skin, and this is known as corrugative cutis anus. Okay, this is the corrugation in the last part, and this 8 mm is actually real skin. It's skin. This is keratinized stratified squamous epithelium. this is having the hair follicle, this is having the sebaceous gland. Yet the intermediate part was also developing somatically. This was also developed from the proctodeum, but this part doesn't have the skin, neither having the gland, nor having the sweat gland, etc., or sebaceous gland. But the last part having the real features of the skin, and this is opening into the natal cleft. This is the longitudinal slit. Okay, last part. So any infection in this part, whatever the skin infection, and this is part which is having a defecation area. So any poor hygiene in last 8 mm may infect the hair follicle, may infect the sebaceous gland, and so on, and cause very painful lesions of the skin. A lesion of the skin, that is the peculiarity of the last part. Last 8 mm is actually skin, and this is skin having the hair follicle, sebaceous gland, the sweat gland, etc. And if the hygiene is not good, that can affect it, and this affected part lead to the abscess, which may invade into the issue fossa and so on, and may result in the multiple things. We will discuss next to this one. Then intermediate venous plexus. Sometime due to the constant strain over the intermediate part, this part having the enlarged or engorgeous piles. This is known as external piles. Why I am telling you this is supposed to be external piles? Because these are developing from the somatic area. These are developing from the real plexus of intermediate zone, and these are really painful. If the external plexus is there, the external piles is there, something should be the internal piles. If there is the enlargement, suppose in case of the liver cirrhosis and a portal hypertension, these longitudinal plexus, this may be get enlarged, and the pile may be coming, the root and radical of the pile may be coming above the pectinate line. This is known as internal pile. So the internal pile are usually due to the portal hypertension, or liver cirrhosis, alcoholic liver disease. Okay, whenever the portal hypertension, the terminal part of the radicals of the superior rectal vein gets enlarged, and you can find out if it is enlargement or a pile is above the pectinate line, that is the internal pile, and the pile below the pectinate line, that is the external pile. So very clearly, the pile which is above the pectinate line is a pain insensitive, that is only painful when you are stretching this one, whether cutting, nibbling or so on, that is not producing pain. But if there is the external pile, that in the somatic area which is supplied by the pudendal nerve, inferior rectal nerve of the pudendal nerve, that is really painful. Okay, if the pile below the pectinate line, that is painful. Above the pectinate line, this is not painful. This is only painful in the stretching. Okay, so there is a clear definition. The internal or the superior rectal radicals or anal wall concerned with the internal piles, intermediate zone concerned with the external piles. External piles are usually painful, internal piles are not painful. Okay, but this there are several features are there, as the bright red hemorrhage from the piles and so on. Okay, so intermediate zone concerned with the external piles. We discuss about the clinical applied of the lower 8 mm. If the hygiene is poor, infection to the hair follicle, sebaceous gland, so on, that may create a painful abscess or a lesion. Okay, intermediate zone, a constant strain during the defecation can cause the painful piles, that is known as external piles. These are known as external because it is outside the pectinate line. Okay, if it is above the pectinate line, that may be the constant, there is the strain on the intestine as well as most of the time due to the portal hypertension, and this is known as internal pile. Pain is the beauty of the medical science. If there is no pain, there may be chances that pile may rupture without a pain, and there may be the hemorrhage. Okay, now coming to another feature, sometime the fecal matter which is hard, can rupture, make a fissure about to downward, and then this is known as anal fissure, a tear in the mucosa, a tear in the mucosa, that is known as anal fissure. And this anal fissure, which is a tear, just a tear in the mucosa, may come through the pectinate line and a somatic zone. This is a real painful condition, because as soon as there is a fissure, due to the pain, the sphincter of the anal canal closes. As they closes, the pain increases. Okay, that is something as a child is holding a hot potato. The mucosal tear is painful, which is going especially below the pectinate line, and this fissure, due to the which is produced with the hard stool, cause the spasm of the anal sphincters, that will produce more pain. That will be the really painful condition, and this is anal fissure. Okay, sometime the gland which is opening above this cusp get infected and forming abscess. When this is forming abscess, okay, I'm drawing here, this can create a tract through the ischiorectal fossa, and now this is creating another opening that is known as anal fistula, a two-way opening, one into the anal canal, another one through the ischiorectal fossa, and opening by the side of the anal canal, not in the real canal, and this is known as anal fistula. This is anal fistula. Many a time infection of these anal gland will produce anal fistula. Okay, all the features. Whether we are talking about the anal column, if there is a protrusion of this anal column or superior radical veins due to the portal hypertension or liver cirrhosis, that is internal pile, and it will found the stalk of the internal pile will be above the pectinate line. If we are talking about the mucosa, there may be a projection of the mucosa in between the column, and that is known as anal papillae. Anal papillae. And if there is an infection of the anal gland, that may go to the ischiorectal fossa and making another opening that is known as anal fistula. The intermediate part of the anal canal, which is known as pectinal line, which is known as pectinal zone, that may be having the external piles. And the last part of the anal canal, which is skin, having the same kind of infections. Not only that, if a skin part having a lesion, it invade about the perianal fascia, it may open into the anal canal, and that may again lead into the anal fistula. Anal fistula. The fecal matter is not only coming from the anal canal, this is also coming through the anal fistula, and you have to go for a surgery. Okay, these are features of all three parts of the anal canal. Now coming toward a very important aspect of the anal canal, that is the sphincters of the anal canal. And for the same, I am drawing a very simple diagram. If I want to draw here by the green color, I am forming a sphincter that is known as internal sphincter. The internal sphincter of the anal gland reaches up to the Hilton's line. That is the peculiarity of the Hilton's line, that represented this green line represents the internal sphincter. Okay, this is the internal sphincter of the anal canal up to the Hilton's line. Hilton line indicates the distal most part of the internal sphincter. Internal sphincter is nothing but the circular fold of the GIT, which is forming a involuntary sphincter toward the anal canal. Okay. Not only that, the muscles, levatorni muscle is also reaching up to that zone. Levatorni. That is the peculiarity of Hilton line. Hilton line is a line between the lowest 8 millimeter and the intermediate one. The Hilton line is the line where the last or distal part of the internal sphincter is ended. Okay, Hilton line where the levatorni muscle is converging to both. Hilton line is a whitish line between the last skin, 8 mm skin, and intermediate bluish hue. Okay, so every picture is there. What pectinate line is separating and what the Hilton line is separating. Now I am drawing another diagram to show the different sphincters. Okay, let's talk about the anal canal. Once again, a sagittal view of the anal canal, protruding anal canal, and a little bit, here it is, the protruding anal canal and longer posterior wall, the smaller anterior wall, longer posterior wall, the pubic region, posteriorly the coccygeal part, okay. The first and foremost, just underneath the skin, there is the subcutaneous part of the sphincter. I am numbering them number 1. There is the subcutaneous part. This is the subcutaneous part of the sphincter, and this is the subcutaneous part of the sphincter. Okay? This is the fan-shaped subcutaneous part of the sphincter. This is the subcutaneous part of the sphincter, anal sphincter. This is the subcutaneous, and this is the number 1. The first and foremost, underneath the skin, and that is producing the cutis or corrugation of the anal canal. This is blending with the skin also. Okay, this part is known as subcutaneous part. The middle part is elliptical in nature, because this is not only going anteriorly. Suppose this is the middle part. Okay, sorry, this is the middle part. This is not only going here, but is blending with the coccyx, and this is also going toward merging into the perineal body. This is also going to merge in the perineal body. Okay, this part is second part, and this part is known as intermediate part. Okay, intermediate part or superficial part. Okay, I want to remind you, the lowest part, which is the most superficial, that is subcutaneous part. Second part is the superficial part, which is the elliptical in nature. Posteriorly, it is blending with the coccyx or forming a blending that is known as anococcygeal raphe. I talk about this raphe in the relation, the posterior relation of anal canal also. Anococcygeal raphe. The last part, which is again, I discussed about this one, which is known as the deep part of the anal sphincter. The deep part of the anal sphincter, and this part going toward the pubic symphysis. The lower part is blending with the intermediate part. The upper part blending with the puborectal sling. These all three parts, 1, 2, 3, are part of the external sphincter. If I want to draw here, the first and foremost, by yellow color, this is the subcutaneous part. Above the perineal fascia, second part is known as, this is the superficial part, and third part is known as deep part, which is near about the puborectal sling. This external anal sphincter is supplied by the inferior rectal nerve, which is a branch of the pudendal nerve. That is a somatic supply. Internal sphincter is governed by the autonomic nervous system. So the few features are very, very important. One is anal column, also known as column of Morgagni, 6 to 10 in number, having the terminal part of the superior rectal artery and superior rectal vein, can produce the internal piles, which may be consequences of the liver cirrhosis or portal hypertension. Then there is in between the mucosa, anal wall, which are also known as valve of Bell, which is enfolding of the mucosa, above covered by the columnar epithelium, below covered by the non-keratinized stratified ischemous epithelium, because intermediate zone having the same. Okay. Above this there is the anal sinuses. Above the cusp there is sinus. That is known as anal sinuses. Anal sinus, where the anal gland is opening. Infection of anal gland may produce anal fistula. Tearing of the mucosa may produce the anal fissure, which is very painful, and the protrusion of the superior rectal vein radicle, that is known as internal piles. If you are talking about the intermediate zone, the plexiform middle rectal vein, inferior rectal vein merging with the superior rectal vein, and this zone is when there is a pile, produced pile, that is known as external piles. Okay. Now coming toward the nerve supply by the superior hypogastric plexus, okay, L1, L2. This is the autonomic nervous supply. If we are talking about the somatic supply below the pectinate line, that is the somatic supply pudendal nerve by the pudendal nerve. If I am talking about the arterial supply, you can see the artery is the superior rectal artery, the middle rectal artery, same with the vein, the middle rectal artery, and in turn the inferior rectal artery, which are blending into the anal canal, supplying all these. When we are talking about the venous drainage above the pectinate line, that is superior rectal vein, and all the veins are blending into anal canal. Okay, so this is the portal, this is the potential site for the portocaval anastomosis, because superior rectal vein, which is a continuation of inferior mesenteric vein, which is continuing to the splenic vein, which is continuing the portal vein, is actually blending with the systemic vein from the, that is the middle rectal vein, or tributaries or radicals of the middle rectal vein and the inferior rectal vein. So this is the potential portocaval anastomosis. And if there is a cirrhosis of liver and there is a high pressure in the portal venous channel, there is a bulging of these veins here. That may lead to the melena or bleeding during the defecation. Okay. On behalf of these external sphincter which having a voluntary action, you can hold the defecation. There is the internal sphincter as a puborectal sling and the mucosal fold of the rectum. All these support the holding of the defecation or fecal matter into last part of the GIT. Okay, one important aspect is above the two important line is there, above the pectinate line and the below the pectinate line. If I want to create a difference, above the pectinate line, GIT, the part, first part is developing. From the developing GIT, it is supplied by the autonomic nervous system, the superior radical veins are there, the epithelium is columnar epithelium, and the piles, internal piles which are insensitive to pain, so on. And if we are talking about the below the pectinate line or curvilinear line, the painful somatic supply and other, this is developing from the proctodium or invaginating ectoderm, which is forming the last part of the anal canal. So you have to remember about the difference above the pectinate line, below the pectinate line, above the Hilton line and below the Hilton line, and all these features, every feature. If during the defecation, hard defecation, this anal wall is ruptured, this may be present as a skin tag below, and that is known as sentinel pile, which having no vessel but a skin tag or a part of mucosa which is hanging through the anal canal. So the internal pile, which is developed for the superior rectal artery vein. Number 2, that is the external pile, which is plexiform, enlargement plexiform, anal papillae, anal fissure, anal fistula, and these all are clinical feature within the 3.8 centimeter last distal portion of this one. Not only that, if you are subcut part, usually whenever person or surgeon is operating into this part and goes and is created damage to the external sphincter, which is not very thick, that may lead to the incontinence in defecation. Okay, any damage to the pudendal nerve or damage to the sphincteric part. Damage to the sphincteric part may lead to this fecal matter incontinence, soiling of the undergarments regularly. Every picture of the anal canal having a unique feature, and these unique features are associated with the clinical aspect. So this is one of the frequently asked question in many of the examination, as well as this is the clinically relevant question. Not only that, if there is a one method where whether you can put your finger in the anal canal and you can judge just about 4 centimeters so on. When you rectum, you can palpate the other viscera also, and that kind of examination is known as perrectal examination. Not only that, in the male, if one specific ultrasound probe can be introduced to the anal canal to visualize the near and surrounding structure, related structure like prostate and other structures, urinary bladder and other part, and this kind, especially for the prostate, this type of approach is known as transrectal ultrasonography, TRUS. This is known as TRUS. Okay, perrectal examination in TRUS you can perform. Not only that, if you want to visualize into the rectum anal canal a rigid as well as the flexible proctoscope are there, and you have to see it. But without reading the anatomical feature of anal canal, you will be not able to treat the patient, especially in the surgery department, which is anal fistula, anal fissure, portal hypertension, and so on. So this topic is very, very important from the examination point of view as well as clinically applied. Thank you for the patience hearing. Kindly share and like my video. Thank you.